big button on the panel is to turn the microphone on when you want to speak. The small button next to it, or medium sized button next to it on the panel, is to turn the microphone on. If you leave the microphone on, you will be on the webcast the whole time that somebody else is speaking. All right. So, first thing he says is to turn it on.
All right, good morning everybody and welcome to the Kirklees Health and Adult Social Care Scrutiny panel, our August meeting. We've got a couple of apologies for absence this morning. Councillor Munro, David Rigby and Peter Bradshaw. We've not heard from Councillor Wilson, so we'll see if she comes in late. Minutes of previous meeting then. So we've two sets of minutes from the 19th of June and the 17th of July. Do we agree those minutes? Yes? Are there any points that you wish to bring up under the minutes? Thank you. Interests. Do anybody have any interests they wish to declare this morning? No? Thank you. All items are in public, so we agree to admit members of the public. So we move to wheelchair services in Kirklees. This is a follow-up item from, we had this some time ago, and we've invited people back to talk about the work on the contract that has been ongoing. And so we've a few people here for that item. So before you speak, if you want to say who you are and where you're from, that will be helpful, all right? So is there somebody who wishes to introduce this item, bearing in mind that we will have read the papers? Thank you. Helen.
So good morning. Thank you, Councillor Smage. I'll go straight into the report, just a summary of the report that you've got in front of you, and then if there are any questions, colleagues may be brought in to answer some of those questions. So my name's Helen Sevens. I'm Director of Integrated Commissioning for the two CCGs in Kirklees, which is Greater Huddersfield and North Kirklees, and also Kirklees Council. And I'm responsible for the Senior Responsible Officer for this piece of work across the Kirklees CCGs. My colleague Rona at the back is the Responsible Officer for Calderdale CCG. So I know that concerns have been raised over a number of years in relation to the provision of wheelchairs and the length of the wait and the increasing numbers on that waiting list. And a report, as Councillor Smage said, was presented to the Health, Adult and Scrutiny panel on the 16th of January this year. The report included an update on the waiting times and waiting lists at that stage, and the feedback from service users, which has been an ongoing engagement process since the contract was let in 2014. But at that scrutiny panel, Scrutiny identified a number of other areas that they required further work on, and they are summarised in the report as improving the experience of service users, improving communication with service users, reviewing the waiting list, and ensuring the assessment process was appropriate. So I'd like to draw the committee's attention to page 19 of the report to look at the work that we have been going and highlight some of those areas to you of the progress that's been made. So on page 19, section 4, you can see that the CCGs have now invested an additional £278,000 each for the financial year 2018. And this is to ensure that the key areas identified in the engagement reports are addressed with service providers. On page 23 of the report, you can also identify the vast improvement that's been made in the waiting lists and waiting times, and that we can show that from September 2017 there were a total of 1,954 open referrals, and at the end of June the data is telling us that they have 930 open referrals in that process. We have also done a major piece of engagement with OpCare, and we've got a service development and improvement plan in place with OpCare to ensure that the 18-week pathway, which is a national target, is in place by the end of September this year. I'd just like to go into detail of some further actions now that are not included in the report but are out of that service development improvement plan and the work that's been ongoing with OpCare. So there's quite a list here, but I think they're important that the panel are aware of those things that have been put in place and the improvements that we can now see happening. So I am going to read through them, but Richard, I can let you have them at the end of the meeting. So we know that the assessment process was key, and OpCare with the additional investments have now appointed additional occupational therapists to ensure that assessment process is rigorous and timely. We know capacity has been an issue at their main site, and they've increased capacity by putting 2 new clinical rooms in at Elland, and they've been operational since July 2018. We know that, I've just said, the waiting list waiting times will come down by the end of September to the national mandated times, but they've also put the waiting list initiative in to join the backlog of people that's been waiting a substantial amount of time, and they're clearing that 100 per month, and that is quicker than what we anticipated, so it's really positive news. We've also developed a new access policy, and that will be loaded on the website shortly, and that's had service user engagement. There's also a frequently asked questions now on the website, which again has involved service users in how that's been developed. There's also a You Said, We Did that will be uploaded shortly. A number of areas that service users had identified was actually access to the service, so now a Saturday morning clinic's been introduced, and also the Eddercliff unit in North Kirklees, which had not been utilised as effectively as possible, is now being used for 3 days a week. OpCare have put in another area of work which is around the complex cases, and this is probably related to children as much as to adults, to ensure that the training needs have been met for all the clinical staff for those complex cases to help smooth the assessment process and then the delivery of the chairs. There's also a new monitoring process being put in by OpCare with their suppliers, and that's been rigorously monitored and has now got key lead-in times for delivery of equipment, which will be monitored on a monthly basis. There was also an issue raised by service users that they sometimes couldn't get appointments, and when that's been reviewed, it was identified that a number of appointments were being wasted or that the did not attend rates were quite high. So OpCare again have put in a different process around confirming appointments with service users, and that's being managed centrally by OpCare at their central office, and they're also considering how they'll use text reminders to service users to ensure they're still aware of their appointment and they can still make it the following day, and also potentially on that day they'll get another text. But they're going to pilot that first to ensure how effective that is before rolling that out. They've also updated their computer system, and their staff have received training on that system, and we need to give assurance that we as the CCGs are closely monitoring this with OpCare on a monthly basis, but the senior management team within OpCare are also well sighted on this and are very closely monitoring all the actions in the service development improvement plan. OpCare also organised a supplier day on the 8th of June, and that was well attended with service users and the potential suppliers, so everybody did a sort of meet and greet, were able to ask questions and get minor improvements done on the day. So we've been engaging, as you know, we've got the tender was let in 2014, and the contract extension is being put in place till the end of September next year. So we are now in engagement process to ensure that a new model will be developed and will be fit for purpose going forward as we develop the service specification. So we've been in a further engagement process following Scrutiny Committee, and that's taken the place of a number of events that we've had. So I'd just like to draw your attention now to page 26 of the report, section 8.6 and 8.7. So we've taken on board the evaluation of Health Watch and looked at where there were potential gaps in engagement, and have develop further process to ensure that we're meeting those specific groups' needs. And we've done 2 major consultation events, engagement events on the 11th and the 20th of July, where we've had very positive feedback from service users about how they're feeling fully engaged in that process, and it's not just being lip service, they feel they're being listened to, are actually involved in the development of the pathways and the model going forward. So the next stages for us at the CCGs is we have a post-engagement deliberation event which is planned for the 20th of August. Out of all the information engagement we have gathered, we will be developing the new pathways. They will be in draft form, and then we'll engage again with our service users and the connections with the community groups that we have to ensure that that is the right model going forward. So we'd just like Scrutiny Panel to receive the report as an update, identify the next stages of developments and the timescales that we're working to. Thank you.
Thank you, Helen. Okay. Would it be fair to say that because it just feels as if the CCG is now running this contract, the CCGs are now actually running the contract with OpCare, that you are having to put in more money so they can employ more staff to get the backlog sorted out and the waiting time sorted out, and you are having to help them with their user engagement, etc., and monitoring their performance. So is it that the CCGs have had to have far more involvement in this contract than you would have expected was necessary? And is the end of September achievable?
So unfortunately Martin's not here today. I do know we do monitor contracts on a regular basis, and this is one that has raised some specific issues where we've had to do some detailed work with the provider. I think the report also identifies that the actual demands on the service was much greater than we anticipated from when the contract was let in 2014. And I think the increasing needs of the population, the demands then on the service, has led us to the situation that we did find ourselves in. So I think from a contracting perspective, we're monitoring this contract as closely as we would any other when we know there have been some potential issues. We're being very clear about the service development improvement plan, the timelines that OpCare have got to deliver, and what we are doing now is closely monitoring that process. But OpCare are key in delivering this themselves. They have recognised that there was work to be done, and they've taken it on board, and they are now doing that work to do the delivery. The engagement process, we have responsibilities as CCGs to engage service users, members of the public around services, and I think because again of the issues, this has probably been higher profile, but we have and would have done engagement anyway with service users around wheelchairs as an ongoing process, and I think it's been really beneficial that the feedback that we've had from them from those two major stakeholder events, and has been very positive.
And I realised that the demand was different to what people had anticipated. But OpCare isn't a small company, is it? You know, a lot of these things it should have been doing anyway. Questions from the panel then. Priscilla, do you want to?
You spoke about having additional therapists. It doesn't mention how many you've actually recruited, and I just wanted to find out from the amount of money that obviously has been invested in from CCGs, what's actually gone into actual service, you know, going towards services towards patients themselves and not in the office staff getting things done.
I only know from the report that they have appointed additional staff, and we know there are 2 full-time equivalent occupational therapists that are in there now doing that assessment process and making sure that the needs are met. We can get more detail from OpCare about exactly the breakdown of how the additional finance has been used.
That would be good, thank you. So I can go on to my next question. The next question would be, in terms of wheelchairs for children, previously, in our when you've been here before, we've had this issue with waiting times, and I can see that the waiting time has now been reduced. And I just want to make sure, and I want to actually ask whether the needs of those children are being reassessed when they actually get the actual chair given to them, because in some cases, because they have been waiting, it's not a case of basically they've gone back of the new list to get a new chair. So can you just confirm that is not happening?
So that was a key item that came out of the first stakeholder event that we had in May. We put in measures that will hopefully address that, and we are starting to monitor that through the 4 categories of wheelchair. So the complex needs of children are being closely monitored. So it's not just the new referrals in, but the re-referrals. And then when they are receiving the equipment, making sure it is still right for them at that time, because we know that children do have growth spurts, and the last thing we want them to do is be in an appropriate moulded seating or in an inappropriate wheelchair. So we are monitoring those figures around the children's area.
It would have just been good to have some re-referral figures in there as well, because obviously we've got the referral figures, but not the re-referrals when they come into the system, or when they're asking for more, a different type of a chair.
So we'll ensure that those figures are included in any future updates, and we can let you have copies of that.
Yeah, please, because we understand there are still long waiting times for people, and therefore we've still got a lot of concerns, especially that children are waiting a long time for a chair. Okay.
You mentioned the access policy. Is there anything new that you've included in that policy that you've revisited currently? So is there anything that you can tell us what's new in that?
So the access policy was actually pulled together by Opcare themselves. The CCG did have some input into that. I think there's nothing necessarily new what's in there. It's just they didn't have an access policy before, and it just clarified the pathway into the service, what would happen with do not attends, and it was just something to communicate with patients and users.
So this new appointment system and the missed appointments and the text messaging services and that, is that something new that you've included in that policy? Because you're going to be piloting that, aren't you?
Yeah, that's included now in there, and I don't think it was anything that was particularly new. It's just there for clarity, so everybody's aware and it's communicated.
Yeah, how did you get the anticipated figures so badly wrong? 37%, 53% over original anticipated figures, and what are you going to do about the next lot of commissioning? How are you going to get it better?
So yes, the figures were different to what were anticipated. I believe that the historic contract monitoring activity figures had not been as robust that we would have liked from the previous contract before 2014. So the activity figures we had, as I just said, would not be as robust. Going forward, I think we've got more national data to pull on. There's more data around from other parts of the country that are going through similar processes, and we've got our own needs information now and activity information, which is robust. So any future planning should be based on more robust data than we've ever had before.
Can we just look? Oh, Harry Vance.
Following on from Nell's question, were you not an equal partner in that partnership that you've got the figures so badly wrong and you're going to be going back and revisiting and trying to make amends? Where's that time gone that you weren't able to pick that up prior to now?
So we are here now. We have robust information, and we need to move forward on how we now commission the future service to ensure that it is meeting the needs of the population that we need to, including the levels and the complexity, especially around children.
So is it more children really that's happened? It's not people living longer and being elderly and frail. Then it's more children in need, is it?
My understanding, and I've got no further detail than the figures that are here, is that my understanding of the work that we've done, there are increasing needs of children, complex needs children, because children are born and they are surviving with more complex needs. So we're seeing that all through the children's services. We know that people are living longer, and we know that people live longer with more complex needs now as well. So all that will be built into the needs assessment and what future services will be required.
Again, again back to our previous the previous meeting that we've had. We spoke about repairs to wheelchairs, and there was obviously a problem in trying to get things moving on, making sure that we weren't ordering a new wheelchair just basically for mediocre small repairs. What's now being done to make sure that obviously you've still got that, and the patients are no longer waiting along for small repairs kind of thing?
So we know as part of the Service Development Improvement Plan, the repairs and maintenance aspect is just as important to service users, and there's a revised timescale and pathway will be developed, well has been developed, to ensure that people are trained to be able to deal with those minor repairs on a quicker basis. So that will be part of the process, has been part of the process, and will continue to be in the new model as well. There'll be very clear time limits put in as part of that pathway for maintenance and repairs.
And has that been picked up back with the service user engagement sessions that you've had, or if anything?
Yes, it has, and that's been reflected back. Their feedback is they are seeing a change in that process, so, which is really positive.
Can I ask about the data, please? On page 21, your tables there, pages 20 and 21. Now, I understand these are years 1 to 3. And your table on 23 is the open referrals between September 27 and June 2018, which is when more work was put into this contract. But when you look at these numbers, there doesn't seem to be any sort of pattern, because I was looking to see if there was an equitable service across Kirklees. If the level of service across Kirklees was equitable. So with us having 2 CCGs, the contracts. And if you look at page 20, the average waiting time for new referrals paediatric in year 3 seemed to go down from year 2, but North Kirklees had the highest number. The re-referrals adults, Greater Huddersfield had an increase, so they increased rather than go down, and it was Greater Huddersfield that had the increase. If you look at waiting times for re-referrals paediatric, then between year 2 and year 3, the average waiting time seemed to go up across the 2 CCGs. And then lower down, the table that stands out is at 5.4 is the third table, which is Greater Huddersfield CCG, had the highest number of re-referrals over 18 weeks for adults. There doesn't seem to be any consistency in that. Greater Huddersfield and North Kirklees seem to have different figures across the board for adults and re-referrals and paediatrics. So where do you think that the problems really lie in the system for the wheelchair services? Because when you've got your open referrals at 23, they're actually between September 2017 and June. They've gone down. Yeah, we haven't got the breakdown, but they have gone down. So where do you think it was? Because there doesn't seem to be the same level of service happening across Kirklees. Never mind Kirklees to Calderdale, but the same level of service happening across Kirklees. And surely, when you've been looking at the contract, you've been looking to make sure that those levels of service are equal across that board. And is it paediatric wheelchairs that were the most held up, do you think? Or was it adults? Or were the re-referrals because of the hold-ups in the initial chairs, so that people were coming back in because the chair they just got wasn't fit for purpose? There just doesn't seem to be any pattern there that you can say, right, okay, this looks as if this was the problem. Have you actually identified where the actual problems lay in Opcare's service?
So that's the piece of work that's ongoing. I think the table on page 22, which reflects the June position for the three CCGs about the open referrals and the specialist need. What it doesn't include there is the re-referrals of that number. So, and I think that's the piece of work we need to come back to you with, showing that detail around what are the re-referrals. And we can take on board those comments, because it could be once people, and I don't know the answer to this, it needs looking at. It could be that once you see a high proportion of one particular area, then because the review process is a year or 18 months, then you see the same high level a couple of years later on. But that's something that we can look at in the detail for the needs assessment.
I think my concern is that in any new contract we have an equitable service across Kirklees, but also that it's taken into account that people will come back into the service at regular intervals, and that needs to be planned into the contract, as well as actually having a service that actually the chair you get is actually suitable and is what you ordered in the first place. I think that's important as well. Priscilla, do you want to come in?
Sorry, going back onto my previous bit about service engagements, page 25 of our papers, where we've got a chart showing how the improvements have been rated. Waiting time still comes in at 2.0. Flexibility of appointments is still 2.3, and that's after you've had an extra service put in on Saturdays as well. I'm not quite sure exactly which part of Kirklees it is, whether it's south or north kind of thing, but surely that's quite low, and below the mark kind of thing, so we need to hit 4 at least. So what else are we doing to make sure we increase on that?
This table that's on page 25 under 8.5, that was actually the feedback from the survey that was done towards the end of 2017, so that was before the Saturday clinic was put there.
So not a recent one?
Nothing since, but we can bring that the next time.
Because it'd be a good idea to find out
the difference.
The Eddercliff unit, noticed in your paper that it said that it was available but not being used, and you've said in your update that it's now being used, which is good news. But you've also said about clinical rooms in Elland. So how are these appointments available to people? Obviously, appointments, people will go out to see users to discuss their needs, but are people having to go to Elland for appointments and Eddercliff? Are those the only two places where people are having to go for appointments if they're going to that people are not coming to them? Do you know?
We can check that, but our understanding is they are the two main service points for access. We also know that they do go out into schools. So there's some regular sessions in schools across Kirklees to help support the needs of children. And part of the learning from one of the stakeholder events was actually parents are not always aware that the wheelchair service are going into schools. So part of the learning from that, which they're going to improve on from September onwards, is making sure parents are notified when OpCare will be in the school that their child's attending, so that if parents can be there and want to be there, they can be.
Are there any more questions from the panel? No. Okay, thank you. We know that you've got this workshop on the 20th of August, so I think we'd like feedback from that. But I think we'd also like feedback from when you have put together, through your engagement, your how you would like the contract to look. So the spec, that's the word I was looking for, the spec for the new contract. I think we'd like to look at that in detail before you go out to commission as part of your engagement on your spec. I think we'd like you to come to Scrutiny for us to discuss that as well. Okay, all right. Thank you very much for that. Thank you. We'll just pause a moment while people get to the right places. Thank you. Okay, thank you. To item 5 now, and I think items 5 and 6 will probably run together because one is about the Kirklees Health and Wellbeing Plan and the other is about the West Yorkshire and Harrogate Health and Care Partnership, and I think there's some crossover themes there. The first item, Kirklees Health and Wellbeing Plan, the papers have been circulated. Does anybody want to introduce this item? Do you want to say who you are before you...
Thank you, Councillor Smage. My name's Lucy Cole, so I'm working on behalf of the newly formed Kirklees Health and Care Executive Group, which works across the major commissioning and provision organisations around health and care in Kirklees, and I'm leading on the development of the Kirklees Health and Wellbeing Plan. So, just like to draw your attention to the paper. The first sections really give some background to the development of the plan and really a focus on the coming together of partners in Kirklees to have a Kirklees focus around the health and wellbeing of the population. So there was an existing health and wellbeing plan which was done in 2016, partly to support the implementation of the Kirklees Joint Health and Wellbeing Strategy, and also partly in response to the development of sustainability and transformation plans, which you'll be aware work on a West Yorkshire and Harrogate footprint, but very much focused around the 6 places within that, Kirklees being one. So the coming together of organisations really in May of this year, the chief executives of those main organisations identified in the paper identified that it was an opportune time to reflect and review the health and wellbeing plan to make sure that this was aligned to the priorities and particularly ongoing conversations around integration across health and care in the patch. Briefly, just to outline, in section 4, you'll see that the health and wellbeing plan is still in development at the moment, and this has been ongoing since June time, really having stakeholder engagement with the organisations involved in the strategy, involving partners from the West Yorkshire and Harrogate Health and Care Partnership, and working closely with the Health and Wellbeing Board, the newly formed Integrated Commissioning Board and Integrated Provider Board in Kirklees. Section 5 of the report outlines really some of the key features that appear in the plan. One of the key ones outlined in section 5.1 is the focus around population. So I think probably some traditional planning approaches, particularly in the NHS, has often led us down to focus on services rather than people. So this is very much a focus around the Kirklees population and very much a recognition of the diverse communities that exist within Kirklees. This is kind of outlined in figure 1, where we've been taking an approach around population cohort planning. So the diagram in there identifies that really there is, this is quite simplified, but 4 main population cohorts that live within Kirklees. Living well are largely kind of healthy communities which access minimal support from statutory services. A proportion of those people may be subject to some risk factors which could be related to healthy behaviours such as smoking, excessive alcohol consumption, poor diet or lack of exercise, or it may be linked to social factors such as poor housing, social isolation. The second cohort is largely independent, so we know that a large proportion of people in Kirklees have a long-term condition, for example. However, around 50% of these people are currently managing this largely alone with minimal contact with statutory services. And the focus around this is how can we maintain people's independence and ability to care for their own health and well-being. There's a much smaller cohort of complex people that live across Kirklees, so quite often people who may be elderly, frail, have multiple long-term conditions. So we know that over 65 population with 3 or more long-term conditions is around 30,000 in Kirklees. So this is very much about thinking about a different offer for these people that will help and support them meet their outcomes. And the final group is around urgent and acute care. And this is a largely transient group. So the focus really here of this is that anyone from any of those population cohorts could have an urgent or acute need at any one time. And the idea is that we can swiftly intervene, support them to get back to their previous level of functioning in the most efficient and effective way. Just to note as well that a key to the plan is taking a life course approach, so very much linked to the Kirklees 7 outcomes, how we can enable people to start well, live well and age well. So that's a common thread throughout the plan as part of its development. Section 5.3, I'll just draw your attention to, is very much focused on one of the key pieces of work that's ongoing at the moment, which is around the development of place-based systems of care. And in Kirklees, like other areas and places in West Yorkshire, are focusing around populations of 30 to 50,000, so which is roughly around 9 networks within Kirklees, and really looking about how we can arrange services and organise those around people within those 30 to 50,000 populations that better meets their needs. I think there are 2 parts to this that perhaps maybe doesn't come across strongly enough in the paper that I'd just like to reinforce. That firstly, the forming of those 30 to 50,000 populations has 2 key aspects. One, in the creation of neighbourhoods, and particularly focusing around the creation of resilient communities and how we use our wider assets within those. So thinking very much about utilising our community capacity building skills that already exist in things like Community Plus, the adult wellness model, the national pilot around local area coordinators. And secondly, which is probably, it's termed primary care home in here, but actually could also be called primary care networks, is actually thinking about a totally different offer for particularly those complex group of people that I mentioned. So very much wrapped around services, operating from groups of general practices, and involving much wider community services such as healthcare, social workers, and voluntary and community sector organisations. So just wanted to draw out that there are 2 main facets to that. As part of that, there are some key elements which will underpin all of it, and those are mentioned in the supporting elements section. So really a focus on population health. So by going down the route that we have of looking at population cohort planning, we can look much more around how our data and intelligence can be viewed in terms of population cohorts and give us a much better idea of where interventions can be targeted in different communities. So you'll have seen my population cohort diagram looks roughly equal in terms of each of those population segments. What I would say is that's just illustrative. I think if you looked at that for different communities in Kirklees, it would look very different profile for each of those. And population health management is crucial to understanding some of that. Similarly with population segmentation and risk stratification, supporting that information. Public engagement involvement is a really key part of that. So I think it's not just about an engagement process around the plan. Actually, the fundamentals of this plan will demonstrate that this is about co-production and co-production with people that live in those communities as well as the staff that support them there. So that's very central to the approach. And as you'll come on to see, a focus around maximising digital opportunities. So just quickly to move on around priorities, I think all of the organisations in Kirklees were very keen that we had some priority focus, because I think if you look at the sheer vast nature of what every organisation is doing, we could probably have 800, 1,000 initiatives ongoing which are targeted around the improvement of health and well-being. And taking the joint strategic assessment as a starting point, we were able to pinpoint where we might want to focus our priorities. And this is a prioritisation exercise we went through in a development session of the Health and Wellbeing Board. Essentially, as you'll see from Table 2, on page 7, they're grouped into 3 main areas. The first around tackling the underlying causes of health and wellbeing issues. Second, improving outcomes in experience for the most complex people in our population. And thirdly, how we use our assets to best effect. So they're very much around what you might typically see as enabling functions related to workforce, communities, digital, and estates. Sorry, I'll keep going. I'll be as quick as I can. And just to note there that the Kirklees Integrated Provider Board, which is newly formed, has also identified some key initiatives which it will be driving forward during 2018-19, which link to those priorities, but very much delivery priorities around particularly integrated models of care in the community, which are complementary to the priorities which feature in the Integrated Commissioning Strategy, which at the moment is in draft form.
Thank you. Okay, right. The population segmentation and risk stratification. Would somebody explain exactly what that means and what outcomes you're expecting from segmentation and stratification, please?
Quite probably complicated terminology, which basically focuses around some tools which allow us to look at the Kirklees population in different ways. So, as I've briefly identified during outlining the paper, that there are actually a number, as you'll be aware, of diverse communities within Kirklees. And really this is focused around getting a better understanding of those communities. So we do get a lot of access at the moment to information and data which tells us about the Kirklees population as a whole and a bit of a breakdown about those communities. But essentially these are tools that will enable us, if we're working on a neighbourhood basis of 30 to 50,000 population, to understand the needs and support required for those communities in much greater depth, and also to align our data and intelligence that already exists to that, essentially to improve provision of services. In terms of outcomes, there is an outcomes framework which has been drafted by the Integrated Commissioning Board, which in essence will underpin the delivery of the Health and Wellbeing Plan. So very much a focus around top-level outcomes and what we want to achieve for the population as a whole, and particularly focusing on where we know there are inequalities across the Kirklees population, and drawing on some existing data and indicators that will already be familiar to you. So we know we'll continue to have to collect some of the national and statutorily required data, but also making sure that that adequately reflects people's experiences and personal outcomes within those services.
Right, okay, so on your outcomes on inequalities, how many years do you think that you will be looking at to see if your outcomes on inequalities are improving as part of this plan? What is the length of time that you will be taking to say whether the plan is making a difference on those inequalities?
So the aim of the plan is it's kind of medium-term focus, so it's over a period of 5 years, commencing from this year, 2018-19, and we'll set aspirations for what can be achieved within that 5-year period, but also to set aspirations for the future in terms of what we think will take much longer to address.
It's just that on your priorities, a lot of these inequalities have been there for a long time. And each plan has tried to address these inequalities, and it's not really clear what progress has been made so far, so that you know what your base measurement for your outcomes are to move forward. Because certainly a lot of these words we've seen in a lot of other plans. So how are you going to develop this so it improves those inequalities far more?
Can I just make a comment? I think you're right. I think we've talked about this for a long time, haven't we? And I think, firstly, it's really difficult to do, and secondly, it's really difficult to prove, because some of these things take generations to work their way through. So it's really difficult to say in 2 years we'll have reduced an inequality in X, Y, or Z. Where I think we have moved on generally as systems in both, health and care, is when we're commissioning now, we've got a far greater focus on impact assessments, understanding not just the quality impact of any changes we make, but the equality impact as well, which wasn't something that we did even, sort of 10 years ago in the way that we do now. So I think we can probably commission and make change in a far more informed way in relation to health inequalities than perhaps was the case previously. But I do take the point about how quickly can we demonstrate the impact. That's a bit trickier.
Yeah, I appreciate that it takes a lot of years. In some of these cases, it can take a lot of years. But that's why I was asking, where you're looking from now to the end of your plan to move forward then to the next plan.
Sorry, Councillor Swidge, I just wanted to add that, in essence, I think within this plan there's a real focus on trying to get a balance. So it's not shying away from the fact that there are these really big underlying issues that will take generations to resolve, but actually there are some things and some initiatives that we could quite quickly do that will start to make some impacts in these areas, and actually trying to have a focus on what can we do in the short, medium and long term around some of these. And by having that outcomes framework, starting to really set an ambition to say, well, what can we achieve by the end of the period of the plan and going forward?
Priscilla, you want to come in?
got the primary care home piloting model. Can I ask you what decisions were made to get one in Holmberg and one in Kirklees to, or why did you come across that? Because obviously you spoke about equalities and health and stuff happened, so I'm just trying to get a background as to that.
I'll make a start. One of the things we've learned about the development of primary care networks, I'm going to use the language of networks because I think that to me, I prefer it really, is where they're successful, they've been bottom up. They haven't been forced upon groups of professionals and organisations. They have been developed by people saying we think we can do something different in our locality. So we think we probably stand the greatest chance of success by piloting something like this approach in areas where people are coming to us and saying we're really keen to do this, we'd be really keen to pilot it. And that's why we've identified the areas that we have, because we have groups of practices and other practitioners in that area saying they think there is something that they could do and they would be willing to put some time into making it happen. I take your point, and that might not be the area where the greatest health inequalities lie, but it is our expectation that we would look to learn from those pilots and as quickly as was feasible roll out any successful models into other areas. So it's kind of about being a bit pragmatic and working with those people who want to do something, but making sure that what we don't do is leave other people behind and can bring that through as quickly as we can.
I totally agree, but I was just obviously you can probably see that there's more work cut out because, like we've said, there's some areas that it's a bottom approach and some areas are wanting to, say yes, they need that, but there'll be some areas that obviously are not as advanced and need a lot more work into that. And obviously, it's not when you've got a pilot model kind of all done and dusted and then realise that a lot more work needs to be done in certain areas to make sure that we do have that quality kind of framework there for everybody.
Just add on that, this is where it does start to link to the next item actually, and the integrated care system. There is some resource being made available to us this year to support the development of primary care networks, and what we're going to try and do with that is a bit of a mix of things so that we can focus some resource on the pilots and getting them going, but think about what do others need in order to enable them to get to the same level.
Areas kind of thing, and not just possibly a consultation in a small pocket of area. Yeah. Thank you.
Just following on from Fazila's point about qualities, you're talking about like bridging the equality gap, but then you seem to be putting an awful lot of onus on communities in capacity building. And bearing in mind, a lot of these people will have quite severe health issues. They're not going to be motivated enough to be participating in some of the social activities that you might be encouraging them to take part in. So how effective do you think that model is? And do you have any evidence of how successful it's been so far?
So I think there are a couple of issues in there. Firstly, I think it's about having a variety of offer within those neighbourhoods. So you're quite right that a lot of it does focus on community capacity and the assets within communities. And I think that's largely linked to the focus around prevention. How can we keep people well? And acknowledging that that is the way in which a lot of people access support and networks within their own communities. So having some responsibility around that to ensure that they're resilient. I definitely take the point that a lot of people have complex needs within there, and that's why very much there's that building around the primary care networks aspect in terms of the interaction with statutory services. So these communities and neighbourhoods are very much all interlinked, so actually services within that as well as the kind of non-statutory services and assets within communities. So that's very much a kind of dual part of that to make sure there's an offer for everybody. I think quite often we focused on the very high-end users for good reason, but actually having a true approach to prevention and a life course approach means that we do need to focus on keeping people well as well in terms of their communities. I think in terms of evidence base, there are pockets of this. So nationally and locally, we see that there is evidence around using particularly community assets, things like social prescribing, and supporting people to access networks within their communities does have benefit for their health and wellbeing outcomes. What I would say is that That's in pockets. I think probably nowhere yet is doing that at any great scale and on a planned basis. So I can't tell you to look to a certain area to say where there's huge amounts of evidence that that works, but there are definitely pockets of this in terms of showing positive outcomes for people.
In terms of like social prescribing, there's not enough community groups, particularly I can speak from Battery East. So how effective is it? You know, when it's okay you sort of building these models or telling us about these models, but if the community capacity or the community voluntary organisation is not there, and GPs are not referring them into those agencies, really, it's a non-starter.
So I think you're absolutely right. I think there's two bits to that. So I think there's an acknowledgement that that is the case, that in communities there are differential levels of kind of activation, for want of a better term, and that a disparate range of community groups and organisations that are available. So one of the focuses around building community capacity through models like Community Plus, through the adult wellness model, through local area coordinators, is actually doing that grassroots work to speak to people in communities and find out what actually needs to be there. So if it's not there at the moment, how can we build on that, and how can we start to create some of that infrastructure that's not there at the moment to meet the needs that people have identified. So that's a really strong part of that. In terms of GP referrals, I think you're absolutely right. I think there's probably differential views amongst primary care, particularly general practice, around how much social prescribing can make a difference for people, and really an understanding of what's out there. So I think on a practical note that then there's been an acknowledgement that there needs to be some work around a directory of services in local communities, so actually practitioners know what services are available, because quite often the lack of referral into services is because they're unaware that they're there quite often. So there's a practical aspect to making sure that people know that those services are there, how to refer into them, and what the benefits of them are.
I think as well, when you're looking to see what's available in communities, I think elected members can play a key role in actually providing that information, because there has been instances before when, I know of one just recently, when information was put out about what was available in the community, and it had a whole raft of things that were missing. And therefore, I think engagement with elected members as to what is available in their communities is also a key part of your information gathering.
I think that's actually crucial, and it links to something that was in my head when we were just talking there. I think it's just important to remind ourselves that this is not an NHS plan. This is a system plan for Kirklees. And Lucy said at the beginning she was working on behalf of the Kirklees Leadership Exec, which is made up of a number of health and care organisations, including the council. I think one of the benefits we'll get from our increased focus on working in an integrated way is exactly that. It's that sharing of information that might not naturally come through. And certainly we have regular conversations about, how the development of primary care networks sits alongside things like community hubs and various other initiatives, that the council are already well on with.
Yeah, the pilot sites, the willing partners who are wanting to drive forward this agenda, are any of them on or related to anybody on CCGs?
So it's a bit of a mix. Some of the GPs in those practices are in the CCG governing bodies at the moment, yes, some aren't.
Can I ask around these primary care home models? Have I got it right that this is part of your 30 to 50,000 population? So you're saying about these primary care home models, they're linked with Community Plus and schools as hubs and existing structures. But this plan is about place, not organisations. Yes? It has to be about place and not about fitting place to organisations. So what happens then if you've got GP practices that straddle an area where they will look at different school pyramids and therefore have different school hubs, and maybe communities look to different places for going to services, but that GP practice could have be across that area. How are you going to fit that into your population and your hubs, etc.?
And there's not a neat answer to that, but that's the situation as it is now. And I would argue that's the situation in every CCG in the land. It's always interesting when you look at GP practices and where their populations are registered. It's quite rare just to find a practice where you've got a very neat registered population, because often they can be quite scattered and be quite far away. So that's the sort of thing our people who deliver services are working with now. But it's almost for the individuals, for the people the staff on the ground who will be working together in those groupings, those networks, to understand what will work best for them and where there might need to be a bit of give and take and on the boundary. And it's never perfectly neat. GPs work with registered populations, and those populations can live in other areas. So it's about finding pragmatic solutions, I think, that will work for people.
Because I think it's important that it is about place. It's not about making people fit into the pattern that's there. It's actually making the pattern fit to people and place. I think that's really important. But I wanted to ask about this 30,000 to 50,000, because those are very neat numbers in themselves. And this is about across West Yorkshire. Yes. And so how is that going to be split across West Yorkshire? Are we going to find that there are going to be some cross-boundary, as far as council boundaries are concerned, cross-boundary population splits as well? Because your 30 to 50,000 is not going to all be within certain boundaries, are they?
Yeah, so I guess the first thing to say is that the 30 to 50,000 isn't an upper and lower limit. It's a kind of a best guess of the kind of population you're talking about. In some rural areas it might be slightly smaller, in some very urban areas it might be slightly bigger. We, at West Yorkshire and Harrogate level, we have no intention of saying here's the 50 across West Yorkshire and Harrogate. It's exactly as Carol describes. We're putting this funding out to places, to each of the 6 places, 2.6 million, and we're asking places to use that to support the development of these models in a way that makes sense locally. All of the boundaries, I don't imagine there'll be huge boundary issues across council areas and across CCG areas. I think the example that you and Carol were describing is far more likely to be the case, where you've got GP practices that have got a distributed population with potentially some commuter populations as well, and how you work through those things. But what I think we're saying is that local leaders in places will work together to develop what makes sense. And if the number is 60,000 and the total number across West Yorkshire and Harrogate is 70 rather than 60, nobody's concerned about that. This is a kind of an indication of the scope and scale, I think. And the funding is new funding that we've received as being part of the ICS programme to allow us to progress on this a bit more quickly.
You come on to funding on page 38 of the papers. You give some funding that's part of the Integrated Care System Development Programme. There will be some resources available. So you said transformation, capital, capacity support and expertise from national bodies. So how is that going to work as far as Kirklees is concerned? How are we going to get expertise from national bodies, etc., into Kirklees?
Yep. So in terms of the funding, the way that the funding has worked up to this point is that we've been given very prescriptive pots of funding by NHS England that we have to spend in very prescriptive ways and account for that in prescriptive ways. So within that 32 million, there's 14 million of cancer funding, which was specifically to deliver certain objectives around cancer, which weren't determined by us, which were determined by the national bodies. I think one of the things that we're hoping to achieve through the integrated care system is that we get a bigger slug of money up front, that we've got greater control over and greater discretion over how we use that. How we actually spend that will be determined on a case-by-case basis. But there's a clear expectation that that funding will flow to places. The money's not going to sit at West Yorkshire and Harrogate level. So Kirklees has received or will receive its fair share of the primary care networks money. We've agreed to invest 4 million to support the system during winter, which Kirklees will receive its share of as well. And the principle is that there'll be a transparent and population-based methodology for getting that funding out to systems rather than it sitting at West Yorkshire and Harrogate level. We're kind of, this links to the sort of the governance question later on. I think it will be 1920, I think, before we start seeing the real, the larger sums of money and the greater autonomy around those sums of money, and the way that we make decisions around that will be really important.
Page 40, delivering care closer to home. And you've got the 18% over 5 years target. This is obviously to be discussed as well at the Joint Health and Review Scrutiny Committee. But across Kirklees, care closer to home. You've mentioned about Calderdale and Huddersfield, but there's nothing much about Mid Yorkshire really, and the northern Kirklees side of things as well. And delivering care closer to home, equitable across Kirklees. How are you planning to deliver those targets as part of this work that you're undertaking?
Yeah, I think this is a challenge, I think, in the way that you described, because we're having a separate conversation going on in the JOSC in relation to how the care closer to home side supports any proposed changes to hospital reconfiguration. That if I sort of step back from that for a minute and just think about it from a Kirklees perspective, because that is where the bulk of our work on care closer to home or out of hospital, whatever you want to call it, that's where the bulk of it gets done now. You know, where we're having the conversations about our out of hospital services are in a Kirklees arena, because the key partners there, obviously people like the council, operate on that footprint, and that's absolutely right. I think what you've got in this paper is the position as it is now. So there's a bit of a reflection of the analysis that was done a year or two ago in relation to the Right Care, Right Time, Right Place programme, and also some examples there of work that has happened, I think in both CCGs actually, not just in Huddersfield, yeah. So a number of these examples apply across the board. We will continue to do our commissioning for out-of-hospital services on a Kirklees footprint. That's not to say at times there won't be a case to be made for a service being slightly different in either North Kirklees or Greater Huddersfield, depending on the needs of the population. But increasingly that's the way we're doing it now, so all of our future planning will be done on that footprint.
So, can we look to planned service improvements then? And end of life, I think, maybe is one of them, I think, that you've got. That's, you're expecting that to be provider-led, I think, end of life, yes. So, how are you looking to ensure that, if it's provider-led, that there is an equal service across Kirklees for this? I mean, I know at the minute it's maybe not end of life, but there are services at Kirkwood and at the Rosewood Centre in Dewsbury, and there's one drop-in day at Dewsbury. So that's just an example, okay? So with all of these services, how are you going to ensure that there is equal access or good access to the services that people need within their communities, within their places? I know some of the services will have to be on a wider footprint, but how are you going to ensure that that footprint fits to how people can get to those services and that they can get to them across Kirklees?
So I can respond to the end-of-life question in the fact that, yes, we have set up a new model of care for end-of-life, and that's been based on how commissioners come together, but also how the provider is a key part of that commissioning process, which is really positive because they bring the expertise and the knowledge and the skills to that commissioning process. And therefore, the provider development and the provider board for end-of-life is going to be key. Part of the work will be to look at where services currently exist, where the needs are, and what the opportunities are to work in the new models of care. And while some of end-of-life care may have to be centralised either at the hospice or where the patient and the carers choose that to be, there will be opportunities to work with the local populations of 30 to 50,000 to ensure we're meeting that needs at the local level to support individuals in their choice and place of death.
So I think in all of this then as well, it's how you're going to engage with people. You mentioned about engagement. And it's not just about people who might use a service at the moment. It's about people who can't actually access that service at the moment but need to. So how are you going to engage with people on this plan?
On this plan specifically, or some of the elements within it? I think we talk with the panel all the time about the engagement work we do on any proposed service change. We've got well-established mechanisms in both CCGs and indeed in the council that we will utilise to engage with people about the plan. But actually, I think what's more important is engaging with people about any specific elements within it. I'm not sure you get, sometimes just talking to people about a plan in its entirety is less valuable than talking about a more detailed aspect of service provision, because you can then work with relevant groups and communities. So we'll use the mechanisms that we've got. We're not intending to invent something new, because I think what we've got is a really strong set of networks that we'll continue to work with.
Delayed transfer of care. Who is taking the responsibility and ownership in terms of transferring those patients on? And not a case of basically we need them out of the bed, so sign them off from the hospital, and then there's somebody else's responsibility, and then the patient themselves, I feel that they're in limbo land. A very serious question, because it just sometimes feels like it's gone from one service to the other service, but there's no communication. It's more of a tick box exercise kind of thing, and I do apologise, it just sometimes just feels like that way. But who is then taking that ownership to make sure that there is not just a smooth transfer of the patient itself, but obviously the patient's well-being is being taken care of, not just physically but emotionally as well, because they don't know what's going on.
So on both sides, we're working with the acute trusts through the A&E improvement groups and boards, and they have oversight of the process for delayed transfers of care, and there's some key measures. You're absolutely right, we need to be services to be where the patient is centre, and their carers are supporters through that pathway. There is work in progress to ensure that that is happening. So we're developing roles like the trusted assessor role across both acute footprints to ensure assessments are done in the right place for that individual, and an acute ward is often not the right place. So we're working already about looking at where we might offer support around choice beds, where we can get people stepped into intermediate care facilities, so the appropriate and right assessment process can happen for that individual. There's still work to do, still progress to do, but we are developing that relationship across with both acute trusts, because the relationship, the trust is absolutely key to delivery of this different model of care. And hopefully we're doing things now. I mean, we always talk about winter, don't we? But actually it's the whole year pressure now for acute trusts, and we're already working through some of those new and different models to hopefully have that greater impact. But it needs to be wrapped, you're absolutely right, around the individual and their carers and their needs.
On the frailty on page 45, there's a paragraph there that says frail older people can navigate around an integrated service delivery across the voluntary, primary, community and social care sectors that is available 24 hours a day, 7 days a week where relevant. My question is how? Do you know what I mean? And I know that's probably a very wide question. But how can you navigate if you're unwell and you're frail? How are you going to navigate around all of that? Where is the help to do that? Because you are going to need some help. If you've got family that can help you, then okay. But if you haven't, then how on earth do you get the help you need? It's a paragraph that says a lot but doesn't say very much at all. So what is the plan?
So one of the initiatives we have around frailty, which we're hoping to roll out across Kirklees, is the development of care companions, which is an initiative put in with primary care for them, for when individuals are identified as to be mild to moderately frail, they can have a conversation with the care companion, a plan can be developed, and actually that care companion can help facilitate that navigation through services. And by intervening early and making those connections into the wider communities through Community Plus, the hope is that we can then reduce loneliness and isolation and prevent people escalating up into a greater need for services. It's a service that is only just starting this year, so that is one aspect that we are hoping will help to support people to get around the system.
Sorry, repeat that service again.
It's Care Companions. It's part of an initiative to develop the frailty strategy, which has been identified initially in North Kirklees, but we know we have to roll that out across the whole of Kirklees, but we'll start it there, evaluate it, see how effective it is, and then move on with it.
And how are people going to get referred into it? Or would that be basically just when service users are deemed to be frailed by certain individuals in those health bodies, the services themselves, or is this something that individuals themselves can refer themselves into?
So nationally, GPs now have to identify service users with complex frailty. What we've asked to do is we want to get further up the pathway, so upstream to prevention. So we've introduced that we want mild to moderate frail people identifying as well through an annual assessment process or when they're reviewed. And that's when people will be directed and supported by the care companions. So it'll be probably visit or discussion with GP or practice nurse that will get people into that service.
Annual assessment for the patient or annual assessment for the actual annual assessment? So I'm just thinking if it's an annual assessment, complexities and needs change.
So people do have an annual assessment now when they reach a certain age. That's about reviewing medications and other inputs. We need to make sure that that's happening, because it doesn't always. Some people will require that to be a multidisciplinary assessment, so an MDT, which brings other services and other professionals into that. So that will be the start of the process.
Okay, so can we then has everybody asked the questions on that particular area that they want to? So how does that plug in then to the West Yorkshire side of things? Because you have a diagram on page 59 showing your collaborative forums and your priority programmes and your places, etc. So how does our health wellbeing plan fit into the West Yorkshire side of things? Ian, do you want to come in?
Yes, thank you very much. And I guess I think the starting point for me there's the diagram on page 54, which is the upside down right angle triangle, and essentially what that describes is a sort of a shared service delivery model for organisations in West Yorkshire and Harrogate that all parts of the system have agreed that works for them, and hopefully you'll see that ties in really well with the way that Lucy described the Kirklees plan. So clear focus on preventing ill health, promoting well-being, closer working between local authorities and NHS bodies to achieve that. Population health management isn't a particularly nice term, but it's exactly the right principle. We want to move to a situation where we can better anticipate people's health needs rather than waiting for something bad to happen to them in a blue light taken to a hospital. The second line there is these neighbourhood health and care services, which is the 30 to 50,000 population model. And again, through the ICS, we're supporting maturity of those networks through transformation funding. And then as we move through that, you'll see that there's a greater use of networks and potentially a greater use of single services across West Yorkshire and Harrogate, where it makes sense to do so. So the vast majority of local hospital services will continue to be provided locally through our acute trusts working together as a network across West Yorkshire. We believe that they can learn from each other, improve standards by learning from the best, provide greater service resilience by using staff in a different way. That doesn't mean that services aren't going to be provided locally, and that doesn't mean that individual organisations aren't still responsible. It's just a different way of addressing needs locally. We then move sort of towards the bottom end of the triangle. Secondary hospital services and stroke services are a good example of this, where we've done some work across West Yorkshire and Harrogate, because you need to work at that level to get the right critical mass, and Linda Driver's here and she can provide a bit of an update on that. And finally, tertiary services. So I guess the starting point is that working at West Yorkshire, it's not a new organisation. It's not taking away any statutory responsibilities from individual bodies. It's saying, look, if we collaborate across places and within places, have we got a better chance of delivering services that are more integrated and better meeting people's needs, rather than, so the point that I think you made, Councillor Smidge, organising services around people rather than organising people around services. So if you go to the diagram at the end, there's the sort of four blocks to this, really. The bit at the top, and it's at the top because it's most important, is places. Kirklees is one of 6 places that make up the partnership, and as I said, there's no change in statutory responsibilities, statutory powers, and so that work will still continue at the Kirklees level using the existing governance structures. What we've got down the left-hand side is a set of what we call collaborative groups, or sector-level groups, including a joint committee of CCGs, which is a group of the 9 CCGs working across West Yorkshire and Harrogate. Kirklees are Kirklees are actually 2 CCGs as part of that, so Carol sits on that along with Steve Ollitt and David Kelly. And this is essentially a forum where CCGs can come together and have conversations about things like stroke, where it makes sense to look at them on a bigger footprint. And similarly, you've got a committee in common for the acute trusts, where they do the same thing. They've got a shared programme of work about how they can learn from each other and standardise. The mental health providers have got the same, and West Yorkshire local authorities have got a group made up of executives and council leaders that work at West Yorkshire and Harrogate level on a range of issues, but increasingly focus on health. And the local workforce action board is a West Yorkshire vehicle that brings together health education England with our leaders from our system, so we can ensure that workforce training funds can be spent on things that are most important to us. So those blocks down the left-hand side are essentially groups that we've brought together at West Yorkshire and Harrogate level to help people to collaborate. We've then got a set of programmes on the right-hand side. Again, those involve folk from right across West Yorkshire and Harrogate. I think, Carol, you chair 2 of those, the primary community care one and the maternity one. The carers one is led by Fatima Khan Shah, who's of this parish. The Capital Estates work stream is led by Owen Williams, who is the Chief Exec of Calderdale and Huddersfield FT. And each of those programmes have representation from across West Yorkshire and Harrogate. So folk from Kirklees can play into those programmes, making sure that it meets the needs of people from Kirklees, and again feed back the messages back into the place. And this bit in the centre is a sort of the final piece of the jigsaw, really. This is where we try and sort of make sense of each part of this, because we realise that it's quite complicated. We've currently got a system leadership executive, which is pretty much every chief executive from councils, CCGs, NHS trusts, mental health providers across West Yorkshire and Harrogate. That meets monthly, and its job is to set the sort of the strategic, kind of the overarching strategic direction for the partnership. We're also designing this thing above it called a partnership board, which will be chief execs, chairs, elected members, public groups working across West Yorkshire and Harrogate. That will be a big room. We think there'll probably be 80 to 90 people in that room. It's going to be quite an undertaking, but we think that's important in order to get the right level of transparency, democratic accountability and scrutiny into our work. So it looks like quite a complicated picture, and I appreciate that. Essentially, these are structures to allow us to work together across West Yorkshire and Harrogate where people think it's in our collective interest to do so. There is no power taken into any of these groups. Power is only given, and actually in most cases this is to support organisations to deliver their statutory duties rather than to replace those statutory duties. I don't know whether you want to say anything else, Carol, from a Kirklees perspective.
I suppose only to reinforce the point, Ian, that, like you've said already, all of these groups are populated with people from Kirklees. I think sometimes there is a feeling that this is almost like a separate entity that is doing to us rather than us being part of, and I think you've illustrated it's absolutely not. We're in there in a number of arenas. And actually, certainly, a range of our providers are represented across these mechanisms as well. So hopefully that gives people some assurance that the Kirklees voice is being heard in these arrangements.
In terms of delivering the plan, the model itself, Kirklees-wise, the money that comes in from the ICS or anything else, have we got enough to actually, best way to say, enough to actually make sure that everybody in Kirklees are actually getting a good deal? All the residents in Kirklees are getting a good deal compared to others. Because, I mean, according to the ICS, it's only £1 per person that comes in. So where is the other money coming from, and how is that compared to what other councils are getting in Calderdale, Leeds, or anywhere else?
So the funding that Kirklees receive, through the existing routing of the CCGs from NHS England, the councils, that does not change. So we're not talking about the core allocations that the Kirklees system receives nationally. Whether that is enough to deliver, on the aspirations for the people of Kirklees is a very big question. But we are where we are in terms of the allocation that's been made to Kirklees. What this funding is it's pots of transformation funding, we call it. So it's funding to support delivering services in different ways that we think can be more efficient and deliver better outcomes for population. So the 2.6 million for primary care networks is just one element of the transformation funding that we've received either prior to becoming an ICS or as part of the ICS programme. Is it enough to deliver fully fledged primary care networks across West Yorkshire? Absolutely not. Will it help? Absolutely yes. That's the kind of the position I think we're in. We see the ICS as a benefit from a number of perspectives, but I think we're absolutely clear that we've got a better chance of winning centrally held transformation funding by being part of this programme, part of this process.
You probably would have done some kind of financial feasibility to make sure that it's worth, obviously, for the Kirklees residents. And have you compared that to other councils or other areas? And how have we in Kirklees compared to other areas?
So Kirklees is getting exactly the same as what the other 5 places in West Yorkshire are getting in relation to this funding. It's divvied up £1 per head of population, essentially. So Kirklees is getting its fair share. That doesn't reflect. So what we haven't done in that is said, look, Kirklees are a bit ahead of everyone else, so they get a bit less, or Leeds are a bit behind everyone else, so they get a bit more. What we've basically said is that at this point in time, the fairest way to put this money out is absolutely transparently on a per head of population basis. How we compare with other parts of the country in terms of transformation funding received, I think we've done better than most. I think we haven't done as well as Manchester as part of their devolution deal. I don't think anyone would pretend that is the case. But we've brought in about 80 to 90 million in total by working this way and by developing strong plans for change. And our intention is to absolutely maximise the funding coming into West Yorkshire and therefore the funding coming into Kirklees.
You're just talking at the minute about the transformation funding. You're just talking about the transformation funding. You're not talking about the other streams of funding that have come in. You're just talking about the transformation funding because there are other streams of funding that have supported other initiatives in West Yorkshire, haven't they? Yes, yeah. I think that.
And that was exactly my point I was trying to get at. So obviously, apart from the ICS, what are the other streams of funding? And in terms of the other streams that are coming in, are we getting our equal share there, in that place as well?
So if I understand the question rightly, are you asking whether there's other pots of money that don't directly come to ICS that are we throwing our hat into the ring to? Yeah, so the answer is absolutely yes. So 2 examples of that are capital funding, which isn't allocated down to ICS, so funding to build or repair hospitals and other facilities. And to date, we've brought in about £35 million worth of capital by bidding for that funding, and we will continue to be subject to those bidding processes, and we'll continue to make the best possible case for investment in services in West Yorkshire and Harrogate in terms of the capital pot. I think of the 44 STPs nationally, we are second or third in terms of the total level of capital received. We're a big ICS, so you'd expect us to be getting more than some, but I think we're doing quite well on that. Another example is some of the digital money, so digital and interoperability money, they call it, which is money to support joining up of records across health, social care, NHS organisations, so that we can, share information rather than asking people for the same information again and again. We've just received £7.5 million across Yorkshire and Humber, in this case, for something called local integrated health and care record exemplars, which is a pilot for testing how you join up data to better meet patient needs. So across West Yorkshire and Harrogate, we've just won £7.5 million for that. So you can rest assured that we're absolutely scanning for all of the potential funding opportunities and making the best possible case for investment to come into West Yorkshire.
So I think as well, if I can just add to that, some of those bids, for example, I'm thinking of the one that's come into Leeds for child and adolescent mental health services, one of the first ones. You could look at that from the outside and say, well, that's gone to Leeds, that's not something that's benefiting Kirklees. But actually, our residents will be able to access those services, and that might then mean that they don't have to travel quite as far as they would have done before. So I think it's important to recognise that sometimes bringing money into West Yorkshire will still benefit residents of Kirklees, even if on the face of it, it doesn't appear to actually have gone to Kirklees, if that makes sense.
It does make sense, and you probably kind of said what I was going to ask anyway. So those are really good sums of money that's coming in, and yes, the bit for us here is basically making sure that Kirklees gets its own fair share. And I totally understand that, yes, Leeds might get more because of where it's located and the services that it provides at Leeds Hospital and in those areas. But still making sure that Kirklees isn't left far behind. And I just need to make sure that we feel rest assured that that is going to happen.
Yeah, and Kirklees are around the table in every decision that we make around that, and are lobbying as hard as everyone else in terms of their fair share, so that's absolutely the case.
And actually it links to the discussion on the Kirklees plan. One of the benefits from having a really strong Kirklees health and wellbeing plan is that would support any bids that we would make from a Kirklees perspective into a wider system. That's why it's so important that we have that plan that says what our aspirations are for our place.
And I think you talked about the Kirklees voice. I think it's important to have the Kirklees voice, but that voice is a strong voice and is in all the discussions and provides a way forward for Kirklees, for our complicated health systems in Kirklees. Okay, now we want to come in.
Yeah, could you just explain what the bottom right-hand square business intelligence is in the on page 59?
Yes. Business intelligence is essentially the information that we require to be able to do our jobs effectively. At the minute, very little information actually exists at West Yorkshire and Harrogate level, because West Yorkshire and Harrogate is not a statutory anything. You know, it's a partnership. So if we've made commitments around cancer, maternity, mental health, around the improvements that we want to make, and we need a way of being able to measure how we've done against those commitments. And at the minute, that information exists in a mixture of ways. It sometimes exists at CCG level, it sometimes exists in individual provider organisations, it sometimes exists in local authorities. And what we're trying to do is get the right information at a West Yorkshire and Harrogate level cut, so we can see how we're doing on those things. It's quite technical, but you'd be surprised that it's not always straightforward to aggregate information to a West Yorkshire and Harrogate unit. So that's what that work is focused on.
And can be 53% inaccurate as well, as we found out.
Question around the stroke care homes and where, I mean,
Stroke care homes?
The stroke care homes, the communication, the facilities and the services we offer for stroke care. I mean, at the moment it's very limited for people that live in Kirklees. We're going into Pinderfield, but according to this, it'd be in Harrogate, how, that just seems to be a long way away kind of stuff.
Clarify as well, your report only refers to the hyperacute stroke unit at Calderdale and Huddersfield. People in Kirklees also go to Pinderfields.
Yes.
But also from parts of North Kirklees, if you need to get to an accident and emergency full blue light, just to be clear what I'm meaning by accident and emergency unit, a full blue light accident and emergency unit, then from parts of North Kirklees, BRI and LGI are actually closer than Pinderfields if the ambulance needs to take you to the nearest one for whatever reason. So I think it's important to us about what happens hyperacute stroke units, that everybody in Kirklees will go to, not just one. Okay. So if you're asking about the stroke networks and the stroke units that the question's about, can you not just refer to just one unit? It's important for the whole of Kirklees as several units as well.
Yes.
Yes.
Okay. Okay. Do you want me to update on the report now? Yes. Okay. So, and I'll address that point as part of the update. Is that okay? So, good morning, Councillor Smage and colleagues. My name's Linda Driver. I'm the West Yorkshire and Harrogate programme lead for stroke. The paper's been presented to provide an update on the work we've been doing, to also update you on how the conversations that we've been having with people across West Yorkshire and Harrogate have informed our work today and will continue to inform our work going forward, and to outline the next steps. So, in order to achieve the best stroke possible care wherever people are living across the West Yorkshire and Harrogate, we've been looking and working with the clinical experts, both locally and nationally. We've been seeking the views of the people who use services, including carers, and we've been talking to the staff. As outlined in the paper, we've got 5 hyperacute stroke units currently across, and as you've outlined, those are some of those services are the ones that Kirklees patients would access in terms of Calderdale and Mid Yorkshire. We've been looking at how we can prevent strokes happening, deliver the effective care for people who have a hyperacute strokes, and that's the care they would need in those first 72 hours. And then again, a common theme has been the care that people have after they've had a stroke. So you mentioned around what we've done is, although we've looked at all of the work, there's been a lot of work taking place locally to further improve quality of care across the whole of our specialist stroke services, but variation does still exist. Now, the evidence shows that people who receive care in that's a minimum of 600 new admissions per year is likely to have better outcomes. We've got one of the smaller units, Harrogate, is currently the only stroke service that doesn't receive that number, and therefore work is taking place locally in Harrogate to work through how they can address those issues. So in terms of the West Yorkshire and Harrogate work, we wouldn't, in view of that work, we wouldn't be proposing any further changes, the preliminary outcomes as any further changes to any of the other stroke units in West Yorkshire, including Calderdale and Mid Yorkshire. The paper also not just refers to the work that we've been taking place around those hyperacute stroke services, but it also refers to some of the conversations we've had, and in section 13 on page 62 we share with you some of the work that we've done around the communication and engagement. Now, a strong message through all of that engagement work has been we want people to do as much as we can. People have been saying to us, please do as much as you can to stop strokes happening in the first place. If someone does have a stroke, can we please ensure that the standards of care that our patients receive in any of our stroke units will reduce that variation?
And once someone has had a stroke, when they're being discharged into their local services, can we please make sure all of the care pathway is working for those? So in section 16 of the report, I'll come on to some of the work, and I think this will build on some of the discussion that's taken place in the first two papers. So, for example, in terms of preventing stroke services, stroke happening in the first place, one of the things that we've been doing is around improving the detection, the diagnosis and the treatment of people who have atrial fibrillation, which causes erratic heartbeat. We've also been doing some work around hypertension, which is high blood pressure. And then it's a good example of how the work that's been taking place locally in each of our six areas, including Kirklees, and people working across West Yorkshire and Harrogate have agreed that they want to go further and faster to further improve the detection of these two conditions, which are key to further reducing strokes. So there is some further work, and this is about preventing with the aim of preventing up to 190 strokes over the next 3 years. It's not about duplicating what's been happening in each of our local areas. In Kirklees, there has been work taking place in primary care practices to further improve care around atrial fibrillation and hypertension. It's building on that work, and we've got the Academic Health Science Network working with each of the local areas. Another area is people were saying, if we do have a stroke, please ensure, as I say, the variation in terms of that hyperacute stroke care is minimised, and therefore what we've done is we're developing a hyperacute stroke service specification which sets out those standards of care that we would expect each of those hyperacute stroke units to deliver. And then finally, one of the other pieces of care is, again, around the whole of that pathway working properly. So we started again. Further conversations will take place locally with each of our 6 local areas, including Kirklees, we've developed a draft specification which sets out the key standards that we should be aspiring to achieve for the whole of the stroke pathway, particularly in relation to early supported discharge and community and rehabilitation services and end-of-life care, which I know has been mentioned earlier. We know that those services are commissioned locally, as you've just had a discussion earlier, and therefore we need to have a conversation around with each of the local areas about how they want to take that work forward. And throughout all of the engagement work that we've had, and when we sought the views of people, again, that's a strong message in terms of that. Again, workforce has been highlighted from the work that we've the views that people have given us, and one of the key things that we will be introducing is re-establishing some of the clinical stroke networks, some of our clinicians, the nurses and other therapists that are working in those services would really value in the re-establishment of a clinical stroke network which will encompass all of the people working in each of the acute trusts, Pinderfields and Calderdale, so that they can look at the training, development and supporting those staff as we go forward. And then finally, in view of this, we don't envisage any further changes to hyperacute stroke care at Calderdale or at Mid-Yorkshire. And in view of that, we wouldn't be expecting to needing to consult with the public across the whole of West Yorkshire. Have I answered the question around the stroke? And I am sorry, Councillor Page and to colleagues, if the paper didn't make that clear.
It does. Point 25 goes into it, so yes.
Can we just say as well that the outcomes, having good outcomes across the whole of the units, I think is important for us because of the split of where people go in Kirklees for hyperacute stroke. And I think that is something that is important, that it doesn't matter where you go, the outcomes are good for everybody. Does anybody else have any questions on stroke in particular? Can we ask then how, going back to Annex 1 as well, how this body that's at this West Yorkshire level and Harrogate level, how when you're looking at all these priority programmes, you are engaging with people on them? Because if we just take, I know the cancer one and the carers, you've had a lot of engagement around. But for one of those areas, I do occasionally mystery shop one of the acute trusts. And if I wasn't plugged into this work that you're doing, how would we know that there was actually some engagement around any of these? Because if you go into the one hospital I go into quite regularly, there isn't actually any information there to actually say there's some engagement ongoing with service users on a particular area. So how is that going to improve?
Yeah, and I think that's a really important point, of course. Afternoon, everybody. Or is it still morning? Karen Coleman, West Yorkshire and Harrogate Communications and Engagement. We do publish a lot of our information, but that doesn't mean everybody gets to see what we publish on the website. So I'm very, very mindful of that. Because of the way we work in West Yorkshire and Harrogate with our 6 local areas, for example, Wakefield and Kirklees, we have a large network, over 26 organisations of comms and engagement colleagues. We're in a privileged position because what that brings is around about 70 colleagues working across VCS, carers organisations, all our big health systems, and our councils, the opportunity to use their communication channels. So what we do is we promote and we share all our information via them comms and engagement links as well. When it comes to engagement around our programmes, as you can appreciate, I'm sure a lot of our programmes are in different places. So, for example, stroke, we've done extensive engagement work around stroke, and we've reached between 2,000 and 3,000 people, and we've done our absolute utmost to fulfil the criteria set out in our equality impact statements, where we know that we've had gaps to fill. For example, in some of our African Caribbean communities where we haven't been able to reach them very well, we've gone back and we've tried to address that again. In terms of engagement on a wider level, if you like, we also have all our communication colleagues, contacts within their public patient involvement groups. And we've also set up for West Yorkshire and Harrogate, for the 9 CCGs, it was 11 until they merged over at least to become 1. We have what we call a public assurance lay member group, and we take all our programmes of work that support the joint committee of them CCGs. We take all of that there for public assurance. Again, taking in mind, keeping in the forefront of our mind that the lay members only represent those they're accountable or those in their local areas. We try to top that off with other areas of work. So, for example, we've just done a huge amount of work around mapping out all our access to communication routes for youth forums. And that takes into account people with children in care, which we know health inequalities can be very poor, and that can become a life cycle if we don't understand what shapes their health and well-being moving forward. We've also looking at how, with the new partnership board arrangements with our local councillors and the non-elected members, how we can ensure that partnership boards work. And we've done some co-production work since around April, May time, and that's ongoing, to look at how we can make sure that the voices of people who use our services across all our groups are representative. On top of that, we also do things like we've done a lot of engagement with our VCS organisations, and we've done a lot around carers organisations that support our 260,000 unpaid carers across the area. One size doesn't fit all, not to going around terminology, but we do segment our target groups. We look at how best, whatever programme of work we're doing, will fit that need and how best we can communicate with them using intelligence of how we know what works. We also use a lot of our community assets in our local areas because actually they know far better than us what keeps them healthy and well, and why wouldn't we use that some of the great examples of work we've got ongoing. In terms of wider communications, we try very hard, and I'm absolutely open to constructive feedback of how we can get this better, please. We're still quite a young partnership. We're only 2 years in the making, and we won't have all the answers. But what we are doing now, we're going to be working with Change, a large organisation based in Leeds that covers West Yorkshire and Harrogate, around how we can use people who are employed with learning disabilities on the Change programme, about how we can engage much better with people with learning disabilities. So as we develop, we're constantly looking at where our gaps of engagement and communication are, and we're trying to address them as we go forward. In terms of wider communications, if you like, for me as a member of the public, I think we have a duty, don't we, to actually be community ambassadors, assets and champions for the work that we do. In West Yorkshire and Harrogate, in NHS alone, there's 113,000 employees. If we get our communications right internally, I don't think it would be unreasonable to ask, or to request or to appreciate the impact that they can have as people who live in parts of our local communities. I certainly do. I tell everybody about the work that's going on. Very proud to live in Kirklees, and I'm very proud to work for the partnership. And I think it's our duty and responsibility to explain what that means. I hope that's addressed some of it. That's just a snapshot of the work we do. We, of course, do social media press releases, but we all know that they don't reach everybody either. So we try to do a holistic view.
No, thank you. I think you're okay if you're on a committee or in an organisation. Yes. If you're a patient, how do you feed in your experiences? And sometimes you've got all these organisations that are part of your partnership. If they just had a bit of buy-in and put some posters up in outpatients.
Yeah. Could I do that's it.
It's a simple thing. Yeah. And I think then whichever stream of work you're looking at, if those organisations could actually help, so councils, for instance, could put information in libraries, hospitals could put information in outpatients, GPs could put information on their notice boards. Your work programmes and connecting actually down to your neighbourhood and your places.
I think you're
so
right,
that you're getting the information from those to help support.
Could I give you one example of what we're going to be doing, hopefully, over the next few months? I've written a proposal for our Urgent Emergency Programme Board. Evidence suggests that's when we tell people not to go to A&E, people do. That's the wrong message that we're giving, obviously. So I've just been doing some soft lobbying work, if you like, with our councils, our VCS, our carers organisations, around how we can, this is not the answer to all of it, of course, it's not a one-size-fits-all, but how we can look after our neighbours in dark nights, bonfire nights, winter, making sure we see people. And I think councils are very good at doing that. They're really good. I was working in this council for a lot of years. So we've got a lot to learn from councils and how they engage with their communities. So I'm hoping to get this proposal through the Urgent Emergency Programme Board. I've got the backing of most of our sector groups now, and let's hope that that will be the start of trying to change that conversation as one example.
Councillor Stewart-Turner, you wanted a question?
Yes, hi, I'm Julie Stewart-Turner. I'm just observing today. I'm not chair of Scrutiny, but my question is very similar to the one that Liz has already raised. It was looking at your very busy diagram, which is quite rightly very busy because it is such a massive organisation, so complex with so many people that need to feed into it, so quite understandable. But it was very much a similar point about how this is an opportunity to share with everybody about how the patients help shape those work programmes. So it's not just about informing them, it's about how they help to actually shape the work going forward, shape those priorities.
Yeah. No. Could I answer that if that's all right? Hello, Julie. Sorry, she's a friend of mine, but she won't be easy on me because I know her very well. So how we're shaping what goes on in our 9 West Yorkshire and Harrogate programmes. There's also 7 other programmes, which Carers is one of them, innovation and digital technology as well. What we do is we were trying, and we're just starting to do this work now when our programmes are ready, to get that patient public voice in at the start of every conversation, so that people are in the room. We do recruit members of the public onto our programme board, and where we've done that in stroke. We've also done a lot of work with Health Watch around the cancer and how that they can make sure the patient public voice is representative on the Cancer Alliance work. We have VCS, voluntary community organisations aligned to them programmes, and we have carers organisations too. As we move forward, we need to get better. I'm absolutely admitting that. We need to get better at doing that. And what we can do is that we can try to do some work, and we're just going to, I put a proposal forward with my colleagues in Health Watch around how we can make sure that no conversation without a public or the patient is in that room. We do quite a lot, and we have got a lot of representation on our boards, but we're very mindful that we need to keep doing this and continuing to get better.
Thank you. Ian, you wanted to come in?
Yeah, we had a really interesting discussion with a guy called Professor Don Berwick from the King's Fund a couple of months ago, and we got a set of leaders together to talk about cancer services, and the first thing he said is, you know, why is there no patients in the room? We were thinking, well, it's not that kind of meeting, but he's given us that challenge. You should never discuss anything without having appropriate representation in the room, because it will lead to a better conversation. And so, you know, as you've said, the structures that we're working with are quite complex and have a lot of dimensions to them, but working through how we rise to that challenge is something that we're looking at, and something that's really important to us.
As well, if you're having patients from a particular area, it's important actually to have patients that use different facilities as well, not just one facility, because there are different levels of service sometimes, different experiences depending on where you go for your
and depending
service.
on who you are and what your needs or your communication barriers might be. So like I said, we're going to be working with Change around how we can get better at using some of the expertise that organisations have for learning disabilities. We're starting to look at that for youth forum work, and that's getting a bit of leg around it now, so we'll hopefully be picking up that pace around both of them issues.
Okay, I just want to ask one, have we got any other questions? No, I just want to ask one final question actually, Carol. In your paper on page 44, it says outpatient programme, transformation of the outpatient programme at Calderdale and Huddersfield. Do you just want to outline a bit more about what that is about, please?
So the outpatient programme is something that's actually being led by the Trust. We haven't got Trust colleagues here with us today. I'm happy to talk to you in a bit more detail about it when we meet next week. But the nature of the programme, and there has again been some engagement work done around this, is to try and improve patients' experience of using outpatient services. So we have certainly picked up, partly through the consultation that we did on the Calderdale and Huddersfield patch a couple of years ago, as an example, but also elsewhere, that sometimes that is not the best experience for people. Sometimes people feel they're coming back into an outpatient more often than in an outpatient appointment more often than they need. You know, they're waiting a long time just to be told everything's okay. There's a whole range of things that we can do to modernise the way that outpatient services are provided, and, you know, as a very minimum, save people unnecessary journeys into outpatient services. So the Trust have been looking at how we can make improvements to the way outpatient services are delivered, and I'm sure that will come back through in due course.
Thank you. Yes, I think we'll have a discussion about that. Thank you. Okay, thank you. I think that's all of those items. Thank you very much for coming. The last items on the agenda are the work programme. I think that's as tabled. And the date of the next meeting is in September. In September, we also hope to have representatives from Mid-Yorkshire about one of their services here as well. Okay, thank you very much, everybody. Thank you.